when you think about circuits, how the medications works. Uh, it's made very easy, illustrated by Professor Stahl. Professor Stahl, all of us know him very well, and he's one of the best to make things understandable for all of us. Tonight, he will speak to us about symptoms and circuits in psychiatry, highlighting the neurotransmitters and brain networks of emotional blunting across psychiatric disorders. Uh, Actually, it's my great honor and pleasure to welcome Professor Stahl. Professor Stahl is a professor of psychiatry at the University of California, Riverside University of California, San Diego, honorary fellow at Cambridge University, and senior academic advisor for the California Department of State Hospitals. Is editor-in-chief of CNS Spectrums, the author of over 550 articles and chapters in more than 1,800 scientific presentations and abstracts and 58 textbooks, including the best-selling and award-winning textbooks, Stahl Essential Psychopharmacology. I doubt that any of us doesn't have every edition of Professor Stahl Essential Psychopharmacology. And I myself, I was honored to have one of them signed by him himself. Also, he has the very important Essential Psychopharmacology Prescriber Guide. Dr. Stahl is an internationally renowned clinician, researcher, and teacher in psychiatry with subspecialist expertise in psychopharmacology. And whenever you speak about psychopharmacology, the first name comes to your mind is Stahl. He has received numerous awards, including the British Medical Association Book of the Year Award, the Bennett Award of the Society of Biological Psychiatry, the Distinguished Psychiatrist Award by the IPA, the David Marazic Award in Pharmacogenomics by the ABA, and an honorary doctorate of science by Üsküdar University in Istanbul, Turkey, for his lifetime of achievement in psychiatry. But he is also not only that, but he won all of our love and respect. Whenever we meet, I'm admiring seeing him, and I'm really happy that he accepted me to moderate this session. And all of us, we see how he makes the funny things by the comics to make things understandable to all of us. And I'm quite sure that you'll be impressed and you'll be attracted all the time with Professor Stahl. So please, Professor Stahl, we want to enjoy your presentation.
Thank you, Dr. El-Savai, and welcome to all of you from all across the Middle East. I understand there's several hundred of you, and congratulations with your collaboration with the Maudsley. I have a past history at the Maudsley. I was there for 4 years in the 1980s, back before many of you were born, I think. And so welcome to all of you that are listening both from the Middle East and Europe. And we're going to get started with some ideas here of how we're going to look at anhedonia. So I'm going to share my screen and we're going to get going. So the topic today is anhedonia. Side effect of antidepressants or antipsychotics, or is it an unresolved symptom of psychiatric disorders? And the answer is yes. So we're going to have 3 pretest questions. Now, those of you who are on Zoom can vote. Those of you who aren't on Zoom can watch what they say. And I'm going to ask these 3 questions, and we're going to show you the results, but I'm not going to tell you the right answer. The right answer will come during the talk. Then I'll ask them again, and we'll see if 2 things. Was there any learning? And secondly, was there any teaching? So here we go. Number 1, what's anhedonia? What's the definition? A, the inability to experience pleasure. B, no sensory enjoyment, like a good meal or drink or touching or a warm sunny day. no social enjoyment, being with others. So is it B, or is it C, lack of motivation? Or is the best answer A plus B, or all the above? Go ahead and vote. What is anhedonia? So you'll see the Zoom participants' votes, and you can vote in your own head and see if the presentation changes your mind at all. So how much more time do we need? I guess the votes are still coming in. And let's see if you can show it to me when you get a chance. What is anhedonia? Okay, looks like the results are coming up. You think it's A plus B, and some of you think it's all of the above. Well, that's a good guess, and maybe you already know the answer. 44% of you think A plus B. Let's see what the results show in a moment. So let's go on to the next one, and I'm going to ask question 2 now. What is the next one? Do you know the neurotransmitters of anhedonia? Is it serotonin and dopamine excess, or serotonin and dopamine deficiency, or serotonin excess and dopamine deficiency, or D, serotonin deficiency and dopamine excess? This is an oversimplification, but what is the general thought about neurotransmitters in anhedonia? Go ahead and vote. So we're going to talk first about the neurotransmitters, and then we're going to talk about the circuits. Here are the neurotransmitters. What do you know about serotonin and dopamine and anhedonia? Let's take a look here soon, see how many votes are coming in. This technology is amazing. Too bad we're not face-to-face, but you think it's serotonin and dopamine deficiency is the most popular answer, and I'm going to say that actually that's wrong. So we're going to go and take a look at that and see if you'll agree with me at the end. It might be something else. And let's go to the third question now. The third question is here. What are the treatments for anhedonia? A, reduce serotonergic tone by lowering the dose or discontinuing things like SSRIs or SNRIs. Is that one? Or B, how about enhancing dopaminergic tone by giving bupropion or stimulants when you can, or some of the novel antidepressants and antipsychotics that enhance dopaminergic tone? Or C, do you want to enhance serotonergic tone, or A plus B? What's the correct answer here? How do you treat anhedonia? And this is a little bit related to the previous question. If you knew what was wrong with the neurotransmitters, you're going to know how to treat it. You want to reduce serotonin, enhance dopamine, or enhance serotonin? What's the right answer? And so people think A plus B. I think you're kind of getting the idea how this is going now. You might even be right. So let's go ahead and close this and go on to the slides. So here's the learning objectives. First of all, to present the definition of anhedonia and distinguish it from apathy and other negative symptoms. Now, there's not a huge consensus on what the differences are between these terms, but I will give you what I think the literature is saying is the consensus. Second, we're going to discuss the brain circuits, the neuronal circuits of anhedonia. Where does anhedonia live in your brain? And then what are the neurotransmitters of anhedonia in those circuits? And finally, we'll talk about the medications and drugs that can both cause anhedonia. Yes, drugs cause anhedonia sometimes. And the drugs that treat anhedonia. So let's get started. What is anhedonia versus what is apathy? Well, anhedonia means hedonism. That's come from the word hedonic, means pleasure. Eat, drink, and be merry. Anhedonia means you don't have pleasure. And there's problems with your reward system. Now, the problems with just calling it reward is that we actually today believe that there are at least two types of reward. One is I want to have the reward. You anticipate getting it. So that's feeling good about getting a reward. And that is motivating. And that's sometimes a fancy term for that. You'll see in the literature it's called incentive salience, but it means motivation. You want to get the reward, engage with it. And then you have positive associations. Oh my God, I'm going to get it. Like, oh my God, a lecture by Dr. Stahl. Well, maybe that's not such a great reward, but something. And so then you say the other part of reward is liking. Once you get it, whoa, I'm happy. I've consumed it, if you will. I've had the reward and I have pleasure. So there's the wanting and the liking. The wanting, you'll see, is more about apathy, and the liking is more about anhedonia. Sensory anhedonia means you don't enjoy hugs or tasting food or even sex, and social anhedonia means you don't enjoy interest or spend time with other people. Now, this might not make any difference, these terms, who cares what the difference is, but in the literature, apathy is more a disorder of motivation, drive, and being interested in things. And it's characterized by reduced activities, cognition, and emotion. Apathy is actually a funny thing because it seems to be part of psychotic disorders, mood disorders, and even dementias and cognitive disorders. Whereas anhedonia is more the inability to experience pleasure. Now that's part of apathy, but apathy is more than that. Now, these are not the words used in the DSM and the ICD to actually describe symptoms of particularly depression. But for the purposes of today's talk, we're going to talk more about anhedonia, which is the pleasure, and not so much the drive or motivation to be pleasured. So we also talk to the sensory anhedonia, good meal or drink, touching or being touched, warm sunny day, smelling the forest or the sea, listening to music. People lose this. They don't even care about it. Social anhedonia means they don't want to have contacts with people. In fact, right now, during COVID, this is lost. And so many people who don't get social interactions, who want it, feel deprived and essentially are having forced deprivation of social interactions, which is causing them mood and anxiety problems. Some other variables associated with anhedonia means thinking clearly and focusing. If you have pleasure, you want to pay attention. If not, you don't care. You can't really function well without having pleasure, because pleasures actually dictate whether you do things or get things done. And the other part of this is happiness and meaningfulness. Part of getting life is to feel meaningful and happy. And these are gone when you have anhedonia. Now, anhedonia is not a psychiatric disorder. It's a psychiatric symptom. And it's trans-diagnostic. And what prominent disorders, there are many, that have anhedonia as one of their symptoms. And the biggest one might be major depressive disorder. About 70% of people have anhedonia. And in fact, some people don't have sadness at all. Remember that you don't need to be sad in order to have major depressive disorder. You could have lack of interest or pleasure. Remember that? And some people call that depression without depression, as kind of a funny way of looking at it. But it's possible to be a major depressive disorder with anhedonia, so more so than sadness. Bipolar depression is really the same, but also schizophrenia, in which anhedonia is one of the negative symptoms. Substance abuse, particularly once you're addicted, has a lot of anhedonia, which is basically people start to get drugs because they want to have pleasure from them, and then they get compulsive to actually reduce withdrawal. So they want to get away from terrible things, but they don't want to get a good thing because all the drugs do is take away bad. They don't actually give you a pleasure after you're addicted. PTSD can also have anhedonia. And probably Parkinson's disease is a big part of the mental part. It's in fact, when somebody is getting anhedonic, they may not be getting major depressive disorder. They might be having what's called a prodrome, or the worry harbinger, a threat of either dementia or Parkinson's disease. So sometimes the symptoms becomes before the movement disorder or the cognitive disorder. So let's start with schizophrenia. So the description or phenotype of schizophrenia can be both positive and negative symptoms, as you know. Positive symptoms, of course, every medical student knows, are delusions and hallucinations. But of course, negative symptoms actually combine both apathy and anhedonia. There's also cognitive blunting, sometimes called the cognitive symptoms of schizophrenia. And finally, there's a thing called neuroleptic dysphoria, which begins to talk about the problem we have in schizophrenia, telling whether a negative symptom is part of the illness or part of the treatment. Because neuroleptics, particularly the old ones, particularly at high doses, can cause apathy and anhedonia, on top of the illness causing those things. So here are the symptom dimensions of a major depressive episode, according to the DSM. And you see at the top, you have to either have depressed mood or loss of interest. They don't call it apathy. I'm putting that in there. And in apathy, there also is a part of apathy is anhedonia. This gets a little bit confusing, but lack of pleasure, lack of interest, lack of motivation is a big part of depression, however you want to call the symptoms. And you have to have several other symptoms, of course, as well. But apathy is part of major depressive episodes, whether they're unipolar or bipolar. And one of the things that we don't emphasize, I think, enough in psychiatric training is the difference between negative and positive affect. Negative affect can be defined as sadness and depression. In fact, we in psychiatry, physicians, mental health professionals, we're all into negative affect. We look for sadness. We look for shame, guilt. We look for anxiety, tension, nervousness, stress, agitation. That's what we think about. Irritability, critical, angry, hostile. These are bad things that come when you're depressed. And we want to make them go when you're treated. But as you'll see in a minute, there's also such thing as positive affect, which often psychiatrists don't pay enough attention to. This doesn't come when you're depressed. This goes when you're depressed. And what am I talking about? You lose your energy, lively, active, strong, activation. You lose this. Joy, hope. You lose being understood and warm and affiliative thing. You don't care. You lose the interest and it's not fun anyway. You lose your calm, your content, your zen, your peace, and feeling grateful and compassionate. This is horrible. But if you look at all our rating scales and if you look at what we emphasize for treatment, unfortunately, you'll see the answer is here. A good friend of mine, Koen de Mittenaar, you may know him, he's from Belgium. He did this study a few years ago where he asked physicians in a large number and a bunch of patients as well what they wanted from their antidepressant treatment, and they were not on the same page. Can you believe it? What we find out is that we, on the left, wanted to get rid of all these negative things. We wanted to get rid of negative affect, get rid of the negative feeling, get rid of your despair, your anxiety, get rid of your hopelessness. What the patients wanted was a return of positive affect. So this is often why we think the patient may not be getting better and they think they are, or we may think the patient is getting better and they are not. And so putting these together, and the theme of this talk, in fact, is don't forget anhedonia, because it's what patients want. So what do we want? We're trying to get rid of symptoms because we don't want you to relapse. So that's my priority. I've been guilty of teaching this as well. And so we know the residual symptoms are bad. So patients with residual symptoms will get sick again and recur in another horrible episode of depression faster in 32 weeks. Whereas if you don't have any symptoms, you can go a couple of years, 3 years. So this is why we want to get rid of all these negative symptoms. But the patients are not so much on this page. Certainly everybody wants all their symptoms gone, but in the real world, it's not always possible to get all your symptoms gone. So we tend to want to get the negative symptoms gone, but what do patients want and expect from their treatment for depression? They want return of function. And that really means positive affect. That means no anhedonia. Anhedonia is poison to depressed patients. They hate it. And that's more important for them to get rid of than some of the negative symptoms. So how about schizophrenia? What do we want? Let's get rid of delusions and hallucinations, right? That's the important thing. And of course it's important. But if anybody's treated more than half a dozen schizophrenia patients, you know, in many ways, they either don't have insight into these or they don't really care. What they care about is what? I don't want any more negative symptoms and I don't want any side effects. The patients hate their apathy, their anhedonia, and they sure don't like motor side effects. And they don't want their apathy, anhedonia, and negative symptoms made worse by their treatment. This is the reason schizophrenia patients stop treatment. They don't like these negative symptoms and side effects. Well, let's see how we can understand these symptoms. What are the circuits and what are the neurotransmitters? Now, this is oversimplistic. We don't have a lot of time, but one of the rules that oversimplifies this is that the mesolimbic dopamine system is primarily involved with pleasure and reward, and the mesocortical dopamine system is secondarily involved, but more with motivation and interest. So you could go through all symptoms of depression and all brain areas and try to make a map. In fact, this is something we all should do for every disorder. So I'm going to remind you that there's a little bit of neuroanatomy coming up. The hippocampus, the dorsolateral prefrontal cortex, the DLPFC. It's an important area. You'll see in a moment what is there, but each area of the brain has a different duty. The hippocampus does something different for a living than the DLPFC. Different functions. So if the hippocampus isn't working, you have a different problem, say memory, whereas the DLPFC is more involved with concentration. The anterior cingulate cortex, the hypothalamus, the cerebellum, the amygdala, the ventromedial prefrontal cortex, the VMPFC. All of these are topographical areas of the brain that have different emotional functions, the nucleus accumbens, the striatum, etc. And now if you want to put function on top of that, this is just a node in a network. That's some of the language you're going to need to learn for the future, because we're not just talking about brain regions. That's a little bit old-fashioned, because brain regions are connected to brain regions, and the connection begins to make a circuit. And a circuit has connections between different nerves. sometimes the whole circuit, let's say the circuit of mood, there's a mood circuit, there's a psychosis circuit, whatever. Let's say the mood circuit is also called a network. And the connections between the nerves in that network are sometimes called nodes. So nodes in a network, synapses in a circuit. These are some of the ideas. And so one of the nodes, important nodes, of the mood, guilt, and worthlessness symptom starts at this node in the VMPFC. It also is involved with suicidal ideation, fatigue. I'm not going to spend a lot of time talking about the data or the specifics of this. All I want you to do is leave this lecture realizing that you are in the process in your field of mapping all psychiatric symptoms to brain networks. And each brain network has a different symptom that it controls. And if the information processing in that circuit is wrong, inefficient, low or high, either one, but just out of tune, you have a symptom. So our treatments, what you're doing in your clinic all day long, is tuning circuits, making networks efficient. Did you know you were actually an electrical engineer? Or maybe you were a piano tuner or a guitar tuner. Because what happens is that the strings connecting the various brain areas are like strings on a guitar. And the way when a guitar is out of tune, you put some tension on it, right, with your fingers and the tuning bar. Well, you know, your fingers and tuning bar on those circuits are your drugs. And so all day long, we are tuning circuits. And if we do it successfully, because you know a circuit can be out of tune whether it's too high or too low. And so we have to tune them. And that's actually a more rational way of doing it. So that was the mapping very briefly and very simply for mood disorders, but schizophrenia can also be mapped. We think the negative symptoms, such as anhedonia and problems with motivation, are in the reward circuit, mostly the nucleus accumbens and secondarily in the prefrontal cortex. And it turns out that dorsolateral prefrontal cortex is cognition, these areas, amygdala, etc., for aggression, VMPFC for affective, and mesolimbic. See, the mesolimbic on the purple here, it's too high when you have positive symptoms, but it's other circuits in that same area. Remember, there's a bundle of nerves. Some of the nerves are too high, and that gives you positive symptoms. Other nerves in that bundle are too low, and you can have negative circuit. So what are the neurotransmitters mediating that in the circuits I'm talking about? And this was the answer to one of your pretest questions. We actually think that anhedonia is serotonin excess and dopamine deficiency, and I will prove that to you in just one moment. And the idea is, remember I was talking about mood and affect? Well, we live on this side all the time. We give SSRIs, we give SNRIs, because we're going to get rid of depression, guilt, OCD, fear, anxiety, PTSD, social anxiety, panic, hostility, irritability, go, 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 go. All this is serotonergic. And so serotonin deficits cause this. So we boost serotonin to get that better, right? And here are the serotonin pathways from the RAF-A that can do that. So they come into various brain areas, and we think that by boosting this, we've created a whole generation of antidepressant drugs to change mood, psychomotor symptoms, suicidal ideation, to change vegetative symptoms, etc. But wait, there's a whole other part of the spectrum we might too often ignore, and it's over here. And this is what I told you before. This is the reduction of positive affect. That happens when you have a deficiency, particularly of dopamine. You have loss of happiness or joy, loss of interest, pleasure. Oh, there's your anhedonia. Loss of energy, enthusiasm, alertness, self-confidence. And think about it. Sometimes we not only not treat these, But sometimes our drugs cause these. Have you ever given an SSRI and got rid of sadness and guilt and caused flatness and emotional blunting? Yeah. I'll show you why in a moment. So we need to both improve positive affect by potentially raising dopamine and improve negative affect by lowering serotonin. There are norepinephrine pathways. I don't need to go through that, but there's some overlap with the serotonin pathways. I'm not even going to show you the dopamine, but you get the idea. These are the fingers on the tuning bars. And so if your circuit is out of tune, we can give things that either boost or block all of our neurotransmitters in order to fix it. And the mesocortical areas is also involved with underactivity in schizophrenia, and we think depression, and in cognitive symptoms of bipolar, etc. All these things are involved with anhedonia and the related symptoms of anhedonia in the mesocortical and mesolimbic circuits. Cause bad things. So dopamine deficiency is related to these things, but so is serotonin excess. So let me prove to you that SSRIs and SNRIs can cause emotional blunting, flattening of affect. You already know that antipsychotics, particularly high doses, and particularly old ones, can cause this old thing. Those of you who were trained before 1990, when the second generation antipsychotics started coming out, know very well the so-called neuroleptic induced deficit syndrome. We cause it in our patients all the time with old-fashioned drugs. Sometimes people call this neurolepsis or catalepsy. In animals, it's called catalepsy. They're just sitting there like a bump on a log, nothing. And so let's start first with the SSRIs. So everybody knows SSRIs are involved with serotonin, which comes out. This is yellow serotonin. And then after release is taken back up into the neuron and stored in the synaptic vesicle. And we think it's deficient in patients who are depressed with negative affect. So we boost serotonin to get rid of negative affect. And of course, serotonin goes up. But have you done this? One of the consequences of serotonin going up in various brain areas, including nigrostriatal as well as mesolimbic area, is I'm going to show you here. Did you know that on top of the dopamine neuron lives a serotonin receptor? And so if you're going to increase serotonin in the yellow neuron, guess what's going to happen to the blue neuron? Serotonin's going to go up. It's going to go into that receptor. And look at what happens to the blue dopamine. Have you ever done that to a patient? I have. Flat, apathetic, as a side effect of treating patients for depression. And that is something that we can fix. Now, have you also fixed that? I have too. You can either reduce the dose, or I often add bupropion, occasionally a stimulant, which will make this better. Why? Because it's restoring the dopamine that you just took away with your SSRI. So what we want to do is prevent that when possible, and to realize that sometimes anhedonia is caused by depression and sometimes it's caused by antidepressants. How about in schizophrenia? Sometimes it's caused by the negative symptoms of schizophrenia, but if you take your antipsychotic and put it in here, and you get the production of secondary negative symptoms, and it also happens in the mesolimbic pathway where you get loss of reward. So we can cause anhedonia also with D2 antagonists, particularly at high doses. So what are you going to do about that? Whether it's caused by drugs or caused by illness. It's transdiagnostic, and it's also caused by drugs. Well, this is the answer simply that I was telling you in your test. You should reduce serotonergic tone, which means you either lower the dose or give a different antidepressant that doesn't act on serotonin, or you enhance dopaminergic tone, bupropion. Now, this is not always easy to do in schizophrenia. Why? Because most schizophrenia patients need to be careful about increasing their dopamine tone, or else they become more positive symptoms. Now, some of the novel antidepressants and antipsychotics out there can actually thread that needle between reducing positive symptoms and not worsening negative symptoms. I don't have time in this lecture to go through them in detail, but you can ask me questions and I'll hint about them right now. So we have a symptom-related algorithm for antidepressants in summary for both positive and negative affect. So major depression can be divided into decreased positive affect, which patients care about sometimes more than we do, and that's got to be treated by raising dopamine. On the other side, there's certainly a lot of negative affect in depression, and we certainly do a good job of getting rid of that with SSRIs and SNRIs, but also we need to do both, if at all possible. And so one of the things to remind us about is this drug called bupropion. I call it a norepinephrine and dopamine reuptake blocker. And you've got norepinephrine on the left in purple and dopamine on the right in blue. And it came out of the synapse and is going to go into the reuptake pump. And if you put bupropion in, it will block not only norepinephrine on the left, but also dopamine on the right. Now I'm going to tell you a secret, something that a lot of people don't know. Do you realize that you cannot raise dopamine in the cortex, which is where you want to do it for some of the negative symptoms, remember? But you can't raise it with a reuptake blocker for dopamine. What? You can raise it in the striatum, but you can't raise it in the cortex. Why? There are no dopamine transporters in the cortex. There are only norepinephrine transporters in the cortex. But that's okay, because you can use that information to treat patients if you know what you're doing. So here's the prefrontal cortex. You can tell because the norepinephrine neuron from the right is coming in to talk to the neuron on the left, and it's releasing those purple triangles of norepinephrine. And it only diffuses into that circle because there are reuptake pumps that take it back up into the norepinephrine neuron. Everybody knows that. But look at the bottom. There's no little transporter on that nerve. That must be where in the prefrontal cortex. We know that if you block the norepinephrine neuron at the top, you will increase norepinephrine. Everybody knows that. But you can't increase dopamine at the bottom by blocking the dopamine transporter because there's nothing there. So the dopamine normally has a bigger diffusion in the prefrontal cortex, even without reuptake blockade. Well, one of the things you might not know is that if dopamine's deficient in one of your disorders or because of one of your drugs, you can raise dopamine levels by blocking the norepinephrine transporter, NET, norepinephrine transporter. What? Yes, because if you block the norepinephrine transporter, here's something you might not have known. It also transports dopamine. Yes, the norepinephrine transporter has a higher affinity for dopamine than it does for norepinephrine. So that means that when dopamine diffuses to a norepinephrine transporter, it's taken up and inactivated. So guess what happens if you block the norepinephrine transporter? It not only increases norepinephrine over here, but look at here. It's going to increase dopamine. So pop quiz. How do you increase norepinephrine and dopamine in the prefrontal cortex? By blocking norepinephrine transporters. So that means NDRIs will do that. And so will what? SNRIs, particularly high doses. Now, I don't have time to go through it because time is getting short and we have to go down to questions and so forth. But what I'm going to say now is that one of the new ways to increase dopamine in the prefrontal cortex is with D3 partial agonists. And the only D3 partial agonists that are available that actually are potent enough to do the job are either cariprazine in some parts of the world, mostly the US, it's in parts of Europe, I think it's coming to the Middle East, and blonanserin, which is really only available in Japan. These two drugs will increase dopamine in the prefrontal cortex. What else increases dopamine in the prefrontal cortex? 5-HT1A agonists. And there are a lot of them. You probably have done this. Maybe you've added buspirone to SSRIs for some patients. In some parts of the world, there's vilazodone in the United States. Did you know that vortioxetine is a 5-HT1A agonist? And also look at all these atypical antipsychotics: lorazepam, quetiapine, cariprazine, aripiprazole, brexpiprazole. All of those agents can increase dopamine in the cortex, and in the bottom there, they're actually blocking it in the mesolimbic system. So this is why some of these bottom drugs are not only just used for psychosis, but they're used for depression, sometimes bipolar depression, sometimes to augment SSRIs, and this is why they work. 5-HT1BD antagonists also control downstream dopamine, and the only drug that we know that does that right now that's available clinically is vortioxetine. 5-HT3 antagonists improve downstream dopamine. And what are the drugs that have this action? Mostly mirtazapine, an old friend, but it's also sedating because it's an antihistamine, so there are some problems with that. And vortioxetine, which is a 5-HT3 antagonist. And finally, 5-HT7 antagonists may help this as well. And there are two known, lorazepam and vortioxetine. So sometime if you invite me back, I'll spend some time going through it in detail and talking to you about how it works and why it works and why these drugs raise dopamine. But I think in conclusion, we can say the definition of anhedonia is that it's mostly a symptom of lack of pleasure and lack of reward system working, particularly for having joy. And it's more of a reward problem than a motivation and interest problem. Hypothetically, anhedonia is associated with what? This is coming up. We're going to ask these questions again. Dopamine deficiency and serotonin excess. Where? In the reward system. Several antipsychotics and several antidepressants can cause anhedonia, as well as can several neuropsychiatric disorders: depression, bipolar, schizophrenia, drug abuse, PTSD, Parkinson's disease, dementia. But you have some treatments, not only by lowering the SSRI or SNRI or enhancing dopamine action with some of the old drugs I told you, but I gave you several novel ways to enhance dopamine to help anhedonia. So here we go. Let's go and take a look at the post-test. Let's ask it one more time. What's the best definition of anhedonia? At least the one I was saying I used. Is it the inability to experience pleasure, A, B, no sensory or social enjoyment, or C, lack of motivation? Or is the best answer A plus B, or all of these? In the literature, what's the best definition of anhedonia? I want you to have joy answering this question, and you will give me great joy if the number of correct answers goes up. So what we're going to do is first show your vote when it's in, and then we'll go back and re-show you what you said the first time and see if there was any improvement. So what I'm fishing for here is perhaps A plus B equals C. And we did have some improvement. So it's now up to 55%. What was it before? Let's go back. And it was 44%. So there was some learning. I mean, the reality is it's hard to really define anhedonia, and it's controversial. But I want you to be motivated and not apathetic. So apathy kind of gets into motivation, and more anhedonia just into pleasure. I don't even care. They're so closely related, it maybe doesn't matter. But let's go to the next one, see if there's a bigger bump in your correct answers. You remember what are the neurotransmitters of anhedonia? A, serotonin and dopamine excess. B, serotonin and dopamine deficiency. C, serotonin excess and dopamine deficiency, or the other way around. D, serotonin deficiency and dopamine excess. You remember? Go ahead and vote. The neurotransmitters of anhedonia, at least by simple theory. Too much or too little, and which ones? So we'll do the same thing here as your votes come in. We'll see if you agree with the lecture and if it changed from the pretest. Whoa, look at that. Woo! 87%. I have hedonism, pleasure. Let's see what it was before. It went from 87% correct to, what was it before? Oh my gosh, only 28%. So very good. There's some learning here. Let's try one more now, and then we'll be all done and ready for questions. Post-test question number 3. What are the treatments for this condition of anhedonia? A, reduce your serotonergic tone, or B, enhance your dopaminergic tone, or C, enhance your serotonergic tone, or both A and B. Best answer, please. Can you even treat anhedonia? What do you want to do to serotonin or dopamine for anhedonia? So we'll do the post-test and see what you think. I think a lot of you knew the answer, so I'm not sure you can learn a lot. So A plus B is what we want to be the correct answer, and it's 82%. Let's see what it was before. I think it was pretty high before. 82% correct. What was it pre-test? 48%, pretty good. All right. So you're awake, you're learning, you're having fun. Are you having no anhedonia now, I hope? So we're going to go on and go to the questions and see what we're going to do. So, Dr. Medhat, go ahead and ask me questions.
Yeah, wonderful. As I promised in the beginning, people will never be anhedonic. They'll get much of joy and knowledge at the same time. So this is Tal, as ever, easy and giving knowledge to easiest way in a very enjoyable way. And we have questions, but I'd like also to ask our colleagues and attending from the conference, they can share questions as well. So we received questions from the Zoom room, and we're waiting for more questions from our colleagues and the conference as well. And the other thing that might give more joy, Professor Stahl, is that we have more than 1,000 attendees watching us now.
Wow, so, fantastic. Very good.
This is really great. We have around 1,100 attendees.
Congratulations, a good conference.
Congratulations. And we are honored by your presence, Professor Stahl. The first question is from Dr. Michael Naufal. Thank you, Professor, for the great talk. Really beneficial. An MDD patient, is there any direct correlation between emotional blunting due to treatment and suicidality? So emotional blunting and suicidality, is there any correlation between them?
Between emotional blunting and what? Severity?
Yeah, emotional blunting, that's because of the treatment, because of medication, and suicidality.
Well, people hate lack of pleasure. They hate anhedonia. They hate it. So they do want to escape. And yes, there is a correlation between life not having meaning It's not, why live? I might as well kill myself. So it's not a good sign. But having said that, one of the worst things is agitation and anxiety. That's actually drives you to suicide, perhaps even more. But I think basically people are more passive when they are having anhedonia until they give up. So it's a bad sign. It's a melancholic sign, an old-fashioned melancholic sign.
We're having a rush of questions. The common question is from Dr. Bassem Salah. Would modafinil shift bipolar depression patients into mania?
Modafinil?
Yes.
What did you say?
Is it?
Modafinil.
Yeah, might shift bipolar depression patients into manic episode?
You know, there are some really good studies, and there's also studies of armodafinil, which is really the same thing. And it became this close to being approved for bipolar depression. The problem was they did 3 studies, and only 1 was positive. They were at the end of their patent life, and so they didn't do the second study. But both modafinil and armodafinil are effective for bipolar depression. They were only studied in the presence of a second drug, an antipsychotic. So we don't know about monotherapy, and I might be a bit worried that modafinil would cause mania in somebody who's depressed unless they were on an atypical antipsychotic. So I use it all the time, but I'm usually using it to augment patients with atypical antipsychotics. In the unipolar area, I have no worry because they're not going to go into mania unless they're bipolar and I made the wrong diagnosis.
We have many questions as well from the streaming, from the conference. One of them from Dr. Dea Albert. Sir, in most cases, the depressive symptoms reduces, but anxiety symptoms persist. What is the solution for this?
The
depressive symptoms reduces, but anxiety symptoms continues.
Well, I think the first answer is to not give up, because we need to strive for all symptoms getting better. Because when those circuits have a symptom in it, it's like they're on fire, they're burning. And there's evidence that the longer those symptoms persist, the more brain damage there is. And even in depression, there's brain atrophy, particularly in the hippocampus, and possibly permanent cognitive. And the other thing that happens is that you progress from unipolar depression to bipolar and mixed depressions with continued symptoms. So the only answer is polypharmacy, where you have to try a little of this and a little of that. You have to give serotonin, but if you give too much, you have to back off and give some more dopamine. And so the tools that are available are a number of the atypical antipsychotics. Also, there are complicated pharmacologies in single drugs, such as in vortioxetine. And somebody else mentioned modafinil. I mentioned bupropion. But also the newer antipsychotics, lorazepam, cariprazine, brexpiprazole, and there's a new one in the United States called lumateperone that is actually going to come out. So these drugs were first introduced for schizophrenia, but they're actually quite good for depression. Cariprazine even has a study and where it improved negative symptoms of schizophrenia better than risperidone in a European study. So these are some of the secret weapons to treat these kind of complicated, trying to get everything better at once. You need probably more than one drug.
Another question from Dr. Romeo Jr. Is there any relationship between neurotransmitters and release sites in modeling mental illnesses and its recovery when we talk about mental illnesses like depression and schizophrenia?
So between mental illness and what? What's the relation?
A relationship between neurotransmitters and release sites in modeling the mental illness.
So I don't quite understand the second part.
It's the relation between neurotransmitter and release sites. Is there any release sites of the neurotransmitters? The question is a bit, yeah.
So what's recite? What is the recite?
What is meant is, I think what he means is that the relation between neurotransmitters and modeling of the mental illnesses.
Okay.
Is there
well, I
and
think
the recovery of the mental illnesses as well.
I think in the old days, we used to talk about neurotransmitters and mental illness, but that was like being replaced today by circuits. And neurotransmitters are in circuits. But for example, in the area of psychosis, the psychosis circuit's not just dopamine. It today includes serotonin, because serotonin drugs like pimavanserin can help psychosis in Parkinson's disease and dementia psychosis. It includes glutamate. It includes GABA. It includes acetylcholine because there's a new M1, M4 agonist that actually treats psychosis. So all of these are nodes in a network. And so there are neurotransmitters involved in psychiatric and mental illnesses for sure. But today, it's not just talking about serotonin anywhere in the brain. It's talking about serotonin in a specific connection of a specific circuit for a specific symptom.
Then from Dr. Hussein Tawfiq, on light of your valuable lecture, do you think we have to revise the guidelines?
Well, I think we should revise the guidelines in the sense of making sure that we treat all symptoms and that we don't neglect what the patient wants, which is something we just recognize that it's sometimes our goals and the patient's goals are not perfectly aligned. So I think we should do that. And I think some of the guidelines are based upon, I suppose, cost as well as ease of use. So what we don't have good guidelines for is what happens when the patient is not cured completely better by the first line treatment. All the guidelines are about first line treatments, but I know Dr. Medhat and me and everybody listening rarely treats people first line. Our whole practice all day long is full of people who fail other things. And in that case, we don't have good guidelines. So what I think you do is to take an individual patient after treatment and look at what symptoms are not better. Some got better, but some didn't. That's why they're coming to you. And then you think in your brain, okay, what circuit's involved? What neurotransmitter is involved in those specific circuits? And therefore, what drug can I use? So I try to sort of neurobiologically think through the residual symptoms of each patient one by one, each patient one by one, each symptom of each patient one by one, and try to give a personalized sort of, if you will, sort of like personalized medicine for that patient based on circuits instead of on a gene test.
Thank you very much. Another question for anonymous attendee. Why do we call anxiety and agitation negative affects?
I don't know. You could say, I mean, basically because it's a nasty thing to have. So a good thing to have is joy, and losing it is losing a positive good thing. A bad thing to have is anxiety or agitation, and losing it is a good thing. So I guess the way you say it is that if you have a symptom that's bad because it's there, it's negative. If you have a symptom which is good if it's there and bad if it's gone, that's positive.
Another question from Dr. Maisa Al-Khonezi. What stimulants would you recommend for anhedonia and depression, and at what doses?
Well, I think that somebody mentioned modafinil or armodafinil, which is sort of a soft stimulant that can help. But I use more stimulants, either methylphenidate or amphetamine. I don't know, in some countries they don't have all these meds. And in the United States, there are a number of controlled release formulations which reduce the abuse potential. But one of the secret weapons, if anybody on this call treats geriatric patients, is amphetamine for geriatric depression. People are often afraid of that because it can change blood pressure, and you do have to be careful. But the reality is it's a very good treatment. Many people with geriatric depression become apathetic and anhedonic. And you give them an SSRI, and it doesn't work very well. Most antidepressants don't work very well in geriatric depression, and you know. So I think amphetamine, low doses, 5-10 milligrams, once or twice a day. Give it during the day, not at night, so they sleep. Or give a controlled release form. We have in the United States something called Vyvanse, very, very good. Or you can give, sometimes a small dose of Ritalin, which is methylphenidate.
Another question from Dr. Ahmed Qoraitian. His question is emotional blunting is synonymous to anhedonia? I understand anhedonia is loss of pleasure for the now moment, but apathy of anticipation of pleasure. This is a continuation of his question.
Well, again, you get into these ideas of precision of definitions, and there are different opinions. But, it's good to have emotions. And if you've ever treated a patient who complains of this, they say, I just don't feel. I take this medicine and my depression's better. Thank you very much, doctor. But, I just don't get a really good feel from the soccer game. I don't care who wins. I don't, enjoy buying a new car. What's wrong with me? And so that is what we're talking about, the flattening of emotions. You get a little bit of joy, but you used to, in the old days, get more joy. And so that is what they're talking about, is that the usual emotional reaction to good and bad things every day is gone. And people even want to feel down. They want to feel disappointment. They want to feel, not terrible down, but they want to know that things go up and down. And so that's the flattening. Nothing matters. It's all the same. And that's emotional flattening.
Floods of questions coming. So another question from Dr. Osama Gado. Thank you, Professor. What best choices for treatment depression in schizophrenia?
Well, that's a good question. In schizophrenia, one of the problems is telling the difference between negative symptoms of schizophrenia and depression in schizophrenia. Because, depression can look like a negative symptom. So one of the things you do is treat with just a standard antidepressant. It doesn't matter. It's the first line. Let's just use an SSRI. But usually that doesn't work. And so what I often do is change the antipsychotic. What are some of the best antipsychotics for negative symptoms? It may very well be cariprazine. It may very well even be, I like that one a lot. In the United States, lumateperone is pretty good for that. So maybe brexpiprazole, maybe some others. Lurasidone can work very well for depression in schizophrenia. So I don't necessarily add it to the other antipsychotic. I try to switch them over so that they're getting just that antipsychotic. But I don't mind adding it if I have to.
Another question from Dr. Mustafa Khandil. Firstly, he say, love you, our professor. I would like to ask about, is there any approved evidence for ECT or TMS in treatment of anhedonia?
A little bit. You can get some of that, certainly in depression. TMS, I think the evidence is not as good, but if you've ever treated a melancholic patient lying in the hospital bed in the fetal position, who doesn't care about anything, doesn't want to eat, doesn't even want to live, and you give them ECT, bang, you can see sometimes in one afternoon a complete transformation. And of course, there's a lot of symptoms getting better, but anhedonia is one of them.
Another question I'll read it as it is, but I don't know what will be the feedback about this. Thank you. This is from Dr. Jean-Claude Yazbek. Thank you so much, Professor, for your wonderful teaching. Could you please tell us about your new prescriber guide? How much of added value to previous books, and how does it have online, if there is online access for it?
Okay, this is an advertisement. I'm going to give this man $50 so I can plug my books, right?
Yeah, we'll share it together.
So basically, I just published the 7th edition of the Prescriber's Guide. It is online at NEI, my group, Neuroscience Education Institute. It's free for members. There's also a thing called Stall Online, which is an online version of all seven. I have 70 books now, and 70 books are all online in this portal at Cambridge University Press. So it's also got 6 or 8 new drugs that weren't there in the 6th edition. It's really 3 years or to 4 years since the last version, so we updated that. And so I think it's got that. That's that. Then, by the way, the 5th edition of the textbook is now in press and will come out next spring. It's going. It hasn't been since 2013, so it's been about 7 years. So that'll be out. But I should say, Dr. Medhat, that 2021 is the 25th anniversary, the silver anniversary of my first textbook. So as they're going to celebrate that, I actually have 11 new books coming out in the next 12 months. Various books, just take a look, a clozapine book, plasma drug levels book, a book on suicide prevention, so forth. But please go, and I've been home with COVID, so I'm just writing.
So we thank COVID for such an opportunity that gives us more of your knowledge. The coming questions from Dr. Tazim Danji. She's one of the great speakers that we have in our conference this year. She's telling you amazing talk. Thank you, Professor. Are there any special considerations for treating anhedonia in children and adolescents?
I don't know that there's any special considerations, except that it's very scary when you see it. I mean, children are full of joy and emotions up and down normally, and when they lose it, it just breaks your heart because it's so terrible and so unlike that time of life. So I would say that I would be vigilant for that and treat it aggressively. And you don't forget these, even though they can have side effects and can be expensive. Treating mood disorders in children is very tricky. It causes suicidality and other things. And so often I'm using atypical antipsychotics in very low doses. Again, lurasidone is a very good one. It's got a lot of studies in adolescents, but low doses. And possibly some of these newer ones, like even cariprazine, even though it's not approved for children, maybe more so, or in augmenting SSRIs. So I think the only special considerations is to be wary of the fact that young children have warnings about using these drugs that are traditional antidepressants, and so I sometimes use antipsychotics.
Now we have a question from my dear colleague, and one of the chairs of our conference and member of the scientific and organizing committee, Dr. Ala Hawid. He's chair of medical board in Abu Dhabi. He's asking, is there any link between ADHD and later development of depression? And will stimulant have a role in those patients who develop depression and used to have childhood ADHD?
Well, that's a good question, because ADHD is a problem with dopamine in the same area of the cortex that negative symptoms are. So there can be overlap. And so, yes, you can get improvement of mood as well as attention by stimulants in ADHD patients. However, it's complicated because sometimes the stimulant is better for the inattention than it is for the mood. And the same thing, if you treat bipolar patients, I mean, I used to tell my residents, young doctors, all patients with bipolar have ADHD, but all patients with ADHD don't have bipolar. That's sort of an exaggeration, but you get my idea that there's cognitive problems in mood disorders. So the first thing you do is you treat the mood disorder, if you're bipolar, certainly. The first thing you do for ADHD is you treat the attention disorder and look at the patient. And if they have residual symptoms, then you have to do something different. And in the case of ADHD, you might want to add a stronger norepinephrine reuptake blocker, or like atomoxetine, or you may want to add an SNRI. In the case of bipolar, you probably will add a stimulant and an atypical antipsychotic in the same patient.
Another question from it's anonymous member. Would you still consider stimulants with patients with anhedonia but has a history of addictive disorders?
Oh, I don't like this question. It's too difficult. The reality is that sometimes anhedonia is from the burned out brains of somebody who has been addicted, and they just killed their dopamine off, and it's very dangerous to give those people stimulants. I never say never, but the problem is you might reignite the substance abuse. So if someone was particularly a stimulant abuser, I'd be very hesitant to do that. If they were an alcoholic or even an opioid addict, I'd consider it carefully. But most people are it's a dangerous game. Part of the problem is there's nothing else really to treat it. So I would try the soft stimulants first because they're less abusable, like modafinil or armodafinil. I think that's probably a safer kind of a middle ground to go. The other thing you can do is try an MAO inhibitor, because tranylcypromine is basically an amphetamine. So one of the MAO inhibitors is an amphetamine. And so it's also useful in situations like this where you try to treat anhedonia. And guess what? It increases dopamine very well.
And that was a question from my dear colleague, Dr. Muaz Suddi, who is working in National Addiction Center here for addiction management. That's why he asked the relation with addictive disorder.
Don't forget MAO inhibitors.
Yeah.
It's only people like us that have lost our hair that are old enough to have given an MAO inhibitor. So you people in the Middle East, don't forget, MAO inhibitors are occasionally helpful.
Yeah. Another question from Dr. Muhammad Makhlouf. What is the best diagnosis and treatment for depression for children cancer patients?
I don't think it really is any different than for any other children. Clearly, there's a biological cause, and the fatigue and the sickness behavior that goes along with chemotherapy can sometimes not really be a form of depression, but really a form of illness, and that's not going to respond to antidepressants. But I think what I see often is that too often people say, well, they should be depressed, they're sick, so don't give them an antidepressant because it's rational. That's sort of like saying, well, he fell out of a tree and he broke his arm, but don't fix it because, we understand why he got a broken arm. You still fix it. So yes, I would treat children the same. You treat them carefully with reuptake inhibitors and try to give them motivation and interest. So that obviously you start with the simplest drugs. They have fewer drug interactions, less problems with the liver. It would be something like fluoxetine or escitalopram. If that doesn't work, then you get more fancy and more aggressive.
Another question is from Dr. Walid Wasfi. I saw some patients of the MDD with anxious distress or depression and anxiety disorders, comorbidity, and even schizophrenic patients with anxiety. I saw some of these patients are very comfortable with their emotional blunting from their point of view. Do you agree with that?
Sometimes, yes, because their kind is a reciprocal relationship. The more activated you are, the more anxious and agitated you can get, and the less activated you are, the less. So if people do not like panic attacks, they do not like agitation, and sometimes they prefer being a little bit more down and find that that's a more acceptable outcome. But we can teach them that it's possible, we say in the United States, to have your cake and eat it too, which is you get both, so that you can both lose your agitation and also lose your apathy.
Another question from Professor Maha Younis from Iraq. Thank you for the interesting lecture. My question is how we can diagnose anhedonia in ourselves in these circumstances of lockdown and anxiety.
It's hard. There's no blood test. There's no rating scale, really. I mean, there's some research scales. But I think you do that by asking people, what they do every day and what gives them pleasure and what gives their life meaning. Now, this actually kind of borders into the philosophical a little bit. It's usually not where we go in psychiatry. We go for the symptoms. But in sometimes you say, what do you enjoy? Some people say, I enjoy growing roses. Some people say, I enjoy, watching my grandchildren. The other thing you can do is ask somebody in their life, what is different about the patient? Do they seem to be happy? And what are the signs of activity? About activities. What are the activities that actually indicate happiness? And if they are not doing them, then you can say they may very well have anhedonia. The other thing is that, let me give you an example. This is oversimplification. I can have a patient with depression and say, come on, let's go out and let's go to the pub or let's go to the soccer game. And they don't want to go, they're not interested. And when they go, they don't enjoy it. I can ask a schizophrenia patient to say, let's go out to the soccer game. I don't really want to go. But once they get there, they do enjoy it. So one of them is a lack of interest, and one of them is the lack of enjoyment from activities. So once you get, it's somebody else helps you with the motivation and the interest, actually experiencing it is pleasurable. And so it's important to try to get people to have that experience of pleasure. If they don't have that experience of pleasure, you're in trouble. You have got to go start treating, because the lack of pleasure is not part of the human condition, and it's not compatible with a good outcome.
Another question from Dr. Nagwan Ayad or Ayad. In MDD patients who has anhedonia, if we decrease the dose of SSRI, SNRI, how will that affect the other symptoms of depression, like appetite, sleep, and concentration?
Maybe badly. It's a balance. So if the person's on a real high dose, then sometimes dropping the dose is no penalty. But if the person's on a standard dose and you drop it, then sometimes you can have relapse. So usually in psychiatry, let's say venlafaxine, and you might use 375 milligrams in a very sick patient. Well, if you're getting the mood better and you're getting some of the other symptoms better, but they still have anhedonia, drop the 375 down to 300 or 225. Then you usually are okay. But if you're only taking 20 milligrams of Prozac, 10 milligrams has been approved and maybe it'll be okay, but it's possible that the person would relapse. So it really depends on the dose. And if they relapse, sometimes you bring the dose down of the Prozac or the escitalopram or whatever, and you add bupropion. The thing I like the best, my secret weapon in depression, bupropion. Do you have it in most of your countries?
Um, no, I'm not quite sure. Is it available in all the region or not? The-
Wellbutrin, we called it in the United States in the old days. It's approved for smoking cessation in some countries and not depression. But you need to have this drug if you want to treat anhedonia effectively. And so try to get it off label, try to import it for special patients. Bupropion, fantastic
Yeah,
drug.
we have bupropion in Emirates. We have the two forms, the Zyban, which is used for smoking cessation, and the extended release, we use it for depression. But I'm not sure about the because we have lots of colleagues from different countries of the Middle East and Europe, so I'm not sure is it available everywhere or not. So the coming question from Dr. Rami Ghazi. Great appreciation to you, Professor. At what dose would you think vanilla vaccine will increase dopamine in the cortex system? Is it dose dependent?
Yes, I don't think it will increase dopamine, for example, in the cortex at least 225, maybe 375. In the United States, venlafaxine at 75 milligrams is a primary care physician's drug, and it's just an SSRI. If you want to turn it into an SNRI or even a drug that could help dopamine, you have to use it in the range of 225 to 375.
I'm not quite sure, did we answer this question before, but for MD patients, among the available antidepressant, is there any specific one that has higher efficacy in anhedonia without having emotional blunting?
Well, I think this is why I tend to use more SNRIs than SSRIs in psychiatry, because you can get exactly what the questioner is saying. You can get improvement of depression, but emotional blunting with pure SSRIs. You see that less often with SNRIs. So the first answer is I've stopped using a lot of SSRIs except for OCD, quite frankly. I use mostly SNRIs. And then I put on top of that other drugs, including the new drug vortioxetine could be used for patients. It's got a lot of mechanisms to it. Vortioxetine is like 5 different drugs at once. Otherwise, you can add an atypical antipsychotic to an SNRI. So I don't really like pure SSRIs for this reason, because it causes more flattening.
Another question from Professor Ala Al-Sadadi from Bahrain. What are the update of recommended pharmacotherapy for bipolar 1 depression with anhedonia? Where does esketamine stand in the area of anhedonia?
I don't think there's a lot of publications that have pulled anhedonia out of the esketamine story. I would imagine it probably has some effectiveness for that, but they're mostly concentrating on treatment resistance and mood and sadness and so forth. But I think it has, anecdotally, I've seen it have effect in anhedonia, but it hasn't been, I think, published separately. So I don't know what an analysis of the data would show. We have time for one more question?
We have lots of questions. I don't know how long
we have to
be
leave at
available.
9:30.
9:30? Okay, so we have one question to answer.
Okay, one more.
Yeah. Is doing a genetic study of metabolism of drugs and any comment about cannabinoids?
Cannabinoids.
Yes.
Don't use them.
Okay.
No, I'm teasing. Cannabinoids are probably 40% of my patients are on cannabinoids every day. It's a fact of life. I think it works for pain. I think it can work and help anxiety. To me, it doesn't work well and even can cause what you call apathy. Chronic marijuana will cause an apathetic syndrome. People don't care. They're stoned. Their life is good. They don't care. It's flat. And people do that because they have horrible lives when they're not intoxicated. So that's not a good thing. And it's hard to treat depression when people are on cannabinoids. But I think it's probably an adjunct to pain and anxiety. Obviously, cannabinoids can cause psychosis as well. And it's a big difference because there's CBD versus THC, and you can't get them pure. So if you take more CBD, that's more for pain, and it's probably better for psychiatric conditions. THC is probably toxic to most psychiatric conditions.
That question was by Dr. Nabil Mikati. Dr. Nabil Mikati was the president of Lebanese Psychiatric Association. Last comment is from our dear colleague, Dr. Mufid Raouf, is thanking you, Professor, and it's amazing. Thank you for joining the conference and giving us this wonderful opportunity, such a wonderful learning opportunity. We wish that we have more time. I have now more than 18 questions and counting. And as I told you, we have more than 1,100 attendees, and we have the wonderful style there. So lots of questions, but we appreciate your time, and we thank you very much for such a wonderful night here and afternoon for you, and wish you very safe going out of this COVID era, and go back to watch you live, and because you're amazing virtually, but even more when we face-to-face interact with you. So thank you very much for your time, and we wish to see you soon. And I'm very sorry for the rest of questions, colleagues, because we cannot answer that. We answered more than 25 questions, and we have more than 20. So thank you very much, and have a good night, and see you soon, Professor.
Thank you very much.
Thank you.
Bye.
I enjoyed it. Thank you very much.
Thank you. Thanks for your sharing.
Thank you, my dear.
For over 50 years, the monoaminergic system has been the prime focus of research and treatment in MDD. However, traditional oral antidepressants that target this system still leave 30% of patients unresponsive to treatment.